Nothing relevant. Nothing relevant to the presentation. So bifurcation PCI, it accounts for approximately 15 to 20% of all PCIs. And this is important to remember because we all know that as we have a larger volume, we get better. So on average, an interventionalist in the United States performs approximately 70 PCIs a year. So if 15 or 20% of them are bifurcations, he or she will not see or do a true bifurcation lesion in more than 8 or 10 cases a year. And this is important to remember. So these are specialized techniques and ideally should be performed by experienced operators. Second question is, why should we apply an individualized approach? The answer is relatively simple because there are variations in anatomy. We have left main bifurcation disease, which is obviously much more important than any other bifurcation. We can have it depends upon the plaque burden and the location of the plaque, the angle between the main branch and the side branch. And there are also dynamic changes during the treatment of bifurcation. We can have carina shifts, we can have plaque shifts, we can have dissection. So in other words, no two bifurcations are identical, and an appropriate strategy from the outset saves time and minimize complications. There are several classifications for bifurcations out there. In all honesty, the only one I'm using and I remember is the Medina classification. It's very simple, very practical, clinically useful, and also helpful for research in order to be able to compare populations and results. So you see here you have the main branch, proximal, main branch, distal, and side branch, and depending upon where the lesions are, you can have a true bifurcation 1-1-1, where all branches are involved, 1-0-1. The order of the numbers here depend upon the size of the vessel, and you have all these other variations as you see here. So there's been several studies, and this is a large meta-analysis that showed that actually provisional single stenting is better if it can be performed without having any consequences of losing major branches. You see, however, the two-stent technique is also good as far as main vessel restenosis. Maybe a weaker point is the side branch restenosis. So before we start, I intravascularly image 100% pretty much of my cases, and in bifurcations is extremely important. And both branches of the bifurcation should be imaged, because if you try to conclude, to draw conclusions regarding the ostium of a diag, for example, if you do the pullback indirectly from the LAD, then you may over or underestimate the degree of disease on the diagonal. So please, when you image both side branches of the bifurcation. And there are obviously more recent studies that speak to that point, that IVUS or intravascular imaging has an effect on better quality PCI that is reflected with lower MACE. But this is a relatively old study that shows that especially in left main, PCI IVUS guidance saves lives. My personal opinion is that if you're going to do an left main stenting, let alone a bifurcation, without intravascular imaging, you're going to be in trouble. So I'm going to start by the provisional stenting technique. So bifurcation, keep it simple. We have a large side branch that doesn't have significant disease at its ostium, but obviously we're going to wire both side branches. Leaving the wire there, then we perform PCI and stenting of the main branch. And contrary to what we predicted before, we actually lost the diag. We were able to rewire balloon. It's open. I think it's a very acceptable angiographic result. We leave it as is. So keep it simple. And an important thing is when we do any provisional technique, the wire should cross through the distal struts, because it creates better scaffolding of the side branch than a proximal crossing. And I will show you an example here. If you, on the left side, if you perform a distal recrossing, you see that after the kissing balloon inflation on the bottom left, that there is not so much coverage of the side branch ostium when you're doing it better. I'm sorry. When you do it distally than when you do it proximally. Another important concept is that whenever you perform a side branch inflation, there's the distortion, and you see here on the right side of the slide, of the main branch, especially anything larger than a 1.0 or a 1.5 balloon. I think it should be kissed at the end to avoid this phenomenon. And that's where kissing balloon inflation comes in place in order to reconstruct the carina and correct the distortion of the main branch stent because of the dilatation of the side branch, to the side struts. Okay, bifurcation, stenting, bailout techniques. So you're not planning to go with two stent techniques from the beginning, but you end up after stenting the main branch, realizing that there's a need for stenting of the side branch. So there are three main techniques here. It's the tap technique, which is easy to perform since it requires no recrossing. And you do have the disadvantage there are stents that are protruding in the main branch, making sometimes rewiring of the side branch in the future, or even the main branch sometimes difficult. The other one is the reverse crash, which provides complete coverage of the ostium. The disadvantage is that in order to recross into the side branch, you have to go through 3 layers of stents, and then you can do a bailout culotte, which also offers a very complete coverage of the ostium, but it's a little bit more difficult to rewire through a double stent layer. Another important concept is the geographic miss of the side branch ostium. I think I love performing angioplasty, but the one angioplasty that I hated was an isolated ostial diagonal. Here you have a situation where a stent is placed in a diagonal. The operator thought that had complete coverage of the ostiums. 8-month follow-up, patient comes back with symptoms. There is stenosis, and intravascular ultrasound confirmed that there was a geographic miss. In other words, that the ostium of the diagonal was not completely covered. So these are the guidelines. 1A recommendation is that is for provisional side branch. However, the 2-stent technique, you have also a 2A indication, and the exact reading, as you see, it is reasonable to use elective double stenting in patients with complex bifurcation morphology involving a large side branch where the risk of side branch occlusion is high and the likelihood of successful side branch reaccess is low. So let's talk about 2-stent bifurcation techniques. So here you see a standstill, LAD disease, and first diagonal disease. You see that the side branch is a very large territory. It's bifurcating into an upper and lower port. So it's not unreasonable to think at least that this is going to be a 2-stent technique. The main factor that determines whether we're going to go from the beginning with a provisional technique or a 2-stent technique is the extent of the side branch disease. And it's not only the severity, but also the length. It's very, very common to have what seems geographically very tight ostial diagonal, let's say, disease, as here the example. And you do IFR or FFR, and it's negative. However, if there's a severe and diffuse disease, then it's more likely to be hemodynamically significant, and 2-stent technique should be considered. So this is an algorithm that it's kind of easy to follow. Again, emphasizing that the technique is mainly based on the side branch. So true bifurcation. Do you have significant disease in the side branch? If the answer is no, then you go for provisional stenting. If the answer is yes, then you start asking yourself a series of questions. Is it suitable for stenting? If the answer is no, you just go with provisional. If yes, then how is significant disease defined. Usually we go with 5 to 10 millimeter length from the ostium. If this is a yes, that you go for 2. For provisional stenting. Trying to advance the slide. So again, the approach is dictated by the side branch. Anatomic factors influencing the two-stent approaches. First is the size of the side branch and the main branch. This is something very important for culotte aficionados, that if there's an important discrepancy between the size of the side branch and the main branch, we have to be very careful when we decide to perform culotte, because depending upon the stent and the size of the stent, the side struts can be dilated up to a certain point. And there are specifics in each stent how much you can actually dilate the side struts. If you ask me what they are, the answer is I don't remember. I never learned them. But actually, in every cath lab, we have little cards with this information. So when I do a bifurcation technique, I go and look and see if it is possible to perform a culotte. So if there is important discrepancy, you go with T-stent crash or DK crash. The bifurcation angle is very important. If it's greater than 70, you can go with T-stent, T or TN protrusion. We'll talk about those in a few minutes. If it's less than 70 degrees, the preferred techniques are culotte crash and DK crash. But in addition to anatomic factors, obviously operator experience and expertise matters. Life-threatening presentation or shock always should be taken into consideration. Have someone that has shock, the last thing that you want is to do 8 inflations and 4 or 5 rewirings to do a perfect PK crash. That's not the situation here. Here you just need to go very quickly and save the life of the patient. So these are the techniques that are most commonly in use, and there are variations. So we have the culotte technique, the tap technique, the DK crash that has now many variations, mini, nano, and so on and so forth. And then you have the simultaneous kissing stent. I have to tell you that the last one, the SKS, I've only done it a handful of times, and that has been in cases with distal left main disease, where the patient essentially came to the cath lab with chest compressions or heavy mechanical circulatory support, except for ECMO. So the culotte, you see here that it requires 5 steps and 2 rewirings. The T-stent, it's a little bit simpler, 1 rewiring, 3 steps, and we'll show the examples in cartoons and both in angiograms. Have the DK crash, again, 6 steps, 2 rewirings, 1 to 2 pots, and the SKS is the fastest one. Essentially, you deploy the 2 stents simultaneously, so it just requires 1 step. So whenever you perform a bifurcation technique, in addition to trying to perform it perfectly, technically also think about the patient. If you have an 82-year-old female with an EF of 30%, and you try and do a DK crash, and you're not that fast, and maybe something goes wrong, and you need a prolonged balloon inflation, or you lose wire, next thing you know is that she's going to have a stunt myocardium, and she will be on pressure, so you will wonder why. So just always take into consideration the patient and what your end goal is. Why is the 2-step kiss in DK crash advocated? The answer is shown on those slides. This is the ostium of the side branch. From left to right, without kiss, you see how kind of dirty and the ostium is a lot of metal there. If you do a 1-step kiss, things improve a little bit. And then with the 2-step techniques, you see that maybe it's not in real life that perfect, but you see a nice and clean ostium of the side branch when you look at it head on. DK crash techniques, the steps. This is the only technique of the basic techniques that the side branch is actually stented first. I don't know if you can see my mouse when I'm pointing, but the variations of crush, mini crush, nano crush, or whatever other crush, all are defined by how much of the side branch is protruded into the main branch. So you position the side branch stent first. You put a balloon, and this is very important. If you forget to put a balloon on the main branch before you deploy your stent on your side branch, you may run into the very unfortunate and unnecessary situation where then you cannot get balloons or stents easily down the main branch. So it's very easy to avoid it if you're methodical, and always remember to have a balloon parked next to the side branch before you deploy the side branch stent. After you make sure that the side branch stent is okay, there's no distal dissection or perforation, you remove the SDS and the wire, and then you crush the stent. And then you go in and rewire from the proximal end. I don't really necessarily agree with the way it's shown here on the cartoon, because I don't know if again you can see this is the wire trying to recross. You don't want to recross.
Yeah, we see it.
You do not want to recross through the center of the old stent. You want to actually recross through a side strut. So you really need to make sure that it's adequately crossed. And I also don't like the way this is illustrated here, because that assumes that you have crossed the side branch stent adequately. This is not correct, because the size of this vessel here is much smaller than the size of the vessel here at the bifurcation. We all know that the vessels taper, and there is an equation if you are interested to find it out. I'm not to tell you how much actually it gets smaller after a side branch. So that means that maybe you have not completely crushed the stent here. So when you open it up, you reopen it into the main branch. So I do this, and then I put a much larger balloon, and I just try to crush as much effectively as possible, meaning that I want the two layers of the stents to be essentially touching very tight one another.
You'd use it with non-compliant balloon, or you start with a compliant balloon?
It depends. If sometimes going with a non-compliant balloon, because you don't have enough dilatation and you already have two layer of stent, and then you have 3 layers of stent, maybe a non-compliant balloon will not go in from the get-go. So in this situation, I will try to make some space either with a microcatheter or with a smaller balloon and compliant. But again, at the final inflations and dilatations, I always do a non-compliant balloon. And then we deploy the left main, the main branch, rewire, and then sequential kissing inflations. That's where the non-compliant balloons are critical. Typically, I do at least 22 atmospheres. Very important before recrossing in the side branch stent is to perform a pot. A pot means that you go in and you dilate. You put the dot of your balloon just at the distal part of the bifurcation ostium, and then you inflate it. What that does is it opens up the stent struts, and also opposes the stents, so it makes rewiring much easier. And this is the reason why I recommend that when you do a bifurcation technique, always use a little bit longer stent up here, because you don't want to have any geographic mismatch when you do your balloon inflations for the kissing. So sequential high pressure balloon inflations, and then a kissing inflation at the end at low pressures, 6 atmospheres on each one are enough. I do not perform a proximal pot at the end. I think it's mostly cosmetic. I'm happy to discuss some of the data if there are any questions or interest at the end, and time at the end of the talk. They're just for completeness. There are some dedicated devices. It's the Triton stent. I don't think it got enough traction in the United States. So essentially, it has 3 zones here: the side branch or the transition and the main branch. Essentially, excuse me if my language is not totally appropriate, this is a culotte for dummies. Essentially, it gives you an opening here so that you recrossing is easier to do a culotte here. One of the issues is that the stent that we did in the trials was not medicated with that, was a BMS stent. So anyways, I'm not going to go into the deployment sequence. I just want to share one or two cases. Yusuf, what is the time?
You're good with time. You're good with time.
You
You can
didn't
share
answer my
both.
question. What's the time?
It's 5 to 8.
5.
7:55.
Okay. So I will have at least 20 minutes, right?
Yeah, you can share both cases.
Okay, thank you. Okay, so let's talk about DK crash. Essentially, two dual ostial left main, and you see that there is a 1-1-1 bifurcation here on a large diag. The angle here, actually, this is a mistake. It's probably it's less than 70 degrees. I apologize for it. Again, we discussed about this earlier on, but I would like to emphasize what's the importance of the DK crash versus the standard crash. It creates a much cleaner carina and ostium of the side branch. So first step is pre-dilatation. If the IVUS cannot go in from the beginning, you can start with a compliant balloon. Then intravascular ultrasound for both branches. Then, and this is an important point to make for fellows, the patient also had diffuse disease distal to the bifurcation. So that had to be covered. What is, I think, critical is to avoid double covering the ostium of a side branch with stents before with the stents on the main branch. So here it's nicely illustrated how we decided deliberately to and the stent distal to the bifurcation. So when we put the proximal stent, we only have one layer of stents here before we do the bifurcation technique. Pre-dilating more the side branch. You may wonder why there is a balloon inflated in the LAD. The reason was because it was despite having done one pre-dilatation initially when we went with a balloon, again, it was difficult to get it in. So we inflated a balloon in the stented area of the LAD. It's called anchor technique, so that it increases the support, and then you're able to advance. As you see here, the balloon eventually jumps into the side branch with constant tension on the balloons. Here it goes. The stent placement, as we talked before, in multiple views, need to make sure you have a little bit of stent extending into the main branch. And that's another point I'd like to make, especially for the fellows, is that we need to know the relationship between the stent struts and the dot of the stent. In some stents, it's within a millimeter or so inside the radiopaque marker. In other stents, it's just in the middle. So it's critical to know the differences between the stent so that you avoid missing the ostium of the side branch. And again, the balloon is in the main branch before deploying the stent on the side branch. That's the crash. I left the wire here. There, we can discuss about it, but I haven't had any issues taking it out. Rewiring and the first kiss with appropriately sized balloons. Main branch stent deployment. Proximal optimization technique here that we You see that's what the pot is. So the distal dot of the balloon should be placed pretty close to the distal end of the ostium of the bifurcation, so that when you inflate, you can oppose the stent struts in the proximal part of the vessel, which is much larger than the distal part, as I talked to you before. And it opens up the stent struts also. Rewiring and dilatation, again, you cannot always go with the eventually desired balloon that you want as far as size and characteristics. So sometimes you can go with a 1.5 or 1.0 balloon, or even a microcatheter, to create a little bit of space for your equipment with larger profile to be able to be advanced. And this is the second case. Again, sequential high pressure atmospheres and final inflated. You don't need the final inflation to be at high pressures. You've done the job of dilating anything that you want with the high pressures. At the end, you just want to push the metal back in place. Can you hear me?
Yeah, we hear you well.
Okay, all right, thank you. And this is the final result. You see the pre and post. So it's a very good angiographic result, and confirmed by intravascular ultrasound. So that was a pretty classic TK crush. I just want to share with you a technique that's a little bit more advanced, and I've done it also with DK as well. So this is a technique that is used when you have true bifurcations very close to one another. Not very close, but relatively close to one another. So this the lesions that we intended to treat was this ostial diag, which is significant and more than 5 millimeters, also very large, bifurcating as you see here, calcified, LAD disease, significant pre, and also there was ostial LAD disease, as you will see here, and ostial CERT disease. So essentially, ostial LAD, mid-proximal LAD, first diagonal, and CERT. So 2 bifurcations within relatively close distance. Again, lesion preparation critical. I performed rotational atherectomy in all 3 branches, LAD diagonal, and the left circumflex. Then wire LAD and D1 with pre-dilatation, make sure we have adequate expansion. So the first stent is placed in the diagonal. The idea was to essentially do the same thing in the diag and the circumflex. So put one stent in the side branch into the main branch, as if we're going to do an inverse culotte technique, and do the same thing from the left circumflex. Deploy the left circumflex back into the left main, again, as if we're doing an inverse culotte in the left main. And essentially, the idea to finish it was to put a single stent from the left main into the mid LAD, and then finish with sequential kissing inflations in the diag and the left circumflex. So again, here is the first balloon inflation and stenting crushing of the diagonal. Then you see here that there are balloon inflations in the ostial left circumflex, and then stent placement, post-dilatation in the left main, obviously, and the left circumflex, then rewiring of the LAD through two stents. The first stent is here from the left circumflex into the left main. The second stent is in the diagonal into the proximal LAD. Dilatation of the LAD, both and the stent struts, both in the diag and in the left, the ones coming from the left circumflex. Starting to look reasonable. Rewiring the diag for the second kiss, for the performance, for the dilatation of the culotte, I'm sorry. And then we call it kissing, and again, doing the same thing in the LAD left circumflex. And this is the final result. A little pinched in that high OM/ramus, but good flow and good angiographic result confirmed by intravascular ultrasound in both vessels. Again, this is an advanced technique, not necessarily the first case to do when you go to practice, but it's just something to consider if you have, again, the two bifurcations, one here and one here, in a relatively close distance. And thank you very much for your attention. I'm happy to take any questions.
Thank you very much, Dimitri. That was great. Any questions or comments either from the Zoom or in the room? Yeah. Yeah.
Hey, Dr. Karmpaliotis, thank you for the talk. One of the interventional fellows. I have a few questions, if you don't mind.
A few. How many?
Great.
Let's do one by one.
When you decide to provisional a side branch and it has some disease, do you ever balloon that side branch before stenting the main branch, or do you only rescue it if it goes down?
Actually, when you were starting your question, I got worried because there's no answer to this question, and then I will tell you why. But then when you finished, you asked me ever or only. So the answer is you made it easy because you got, because no, it's not ever and it's not only. So the issue with predilatation of the side branch is that you thinking that you may make it less likely to lose it, or when you stent the main branch, or when you when you stent the main branch. But also the potential problem with this is that you may cause a dissection, in which case it may make the stenting of the side branch mandatory, and when it was probably unnecessary. So it's very difficult to predict. If there is a situation that I don't want to put two stents in, and I think that I may lose it or it's going to get worse, then I may balloon it with a relatively undersized balloon.
You want to keep going? Yeah, keep going.
All right. So the second question is for DK crush. So you had mentioned the importance of crushing your side branch stent and the discrepancy of the size of the main branch, proximal and distal to the bifurcation. So do you size the balloon that you want to crush with according, let's say it's an LAD diag, to the prox LAD or to the distal LAD, since you're going to relatively high pressure, what do you size it to the kind of distal smaller LAD or the proximal larger LAD? And do you ever worry if you're sizing it to the larger proximal LAD about issues distally?
That's an excellent question. So that's why I do two steps. One is I do a high pressure inflation, sizing it to the distal LAD, and then I change my balloon and put a larger balloon, and I do a high pressure inflation, sizing it to the proximal.
And then my last question, also about bifurcations, DK crush, is the importance of crossing in the distal, strut of your side branch stent. And how do you actually confirm that? Do you mag angiographically, or do you IVUS to make sure you're in the distal strut? Because
actually, excuse me for correcting you. It's the proximal that you want to cross.
But then the second one, the initial is proximal, and then the second is distal, right?
I do, well, I do both proximal, to be honest with you. Maybe I got it wrong, and I'm happy to learn from you. But to answer your question, in my experience and what I've seen, not only in what I do, but also what I see the other people doing, either locally or at meetings, is it's very, very difficult to be precise. So I think that this discussion, for example, Antonio Colombo says it's much ado about nothing. That's his opinion, as long as you do a kiss. So I can't really answer the question. If I cross the stent strut and it's not extremely obvious that it's very distal or very proximal, I will just take it.
Yeah. I must be honest, I would, if I recross and then the balloons go, I'm not going to rewire it to get a more.
Yeah, that's what I hear.
Yeah.
People
Exactly.
All right, thank you so much.
Do you have a comment on parts?
So this is Daniel here. When you're set for a DK crush technique, do you have on your mind how much protrusion you want to accomplish with the side branch stenting in the beginning? I know it's dependent on the bifurcation angulation, but you have a rule of how much proximal to the LAD you're going to protrude the side branch stent?
That's an excellent question. And recently, relatively recently, there's been all this discussion, and I think there was a JAC CI paper that was talking about all these variations, mini, nano, traditional, or whatever they want to call it. Again, I'm sure there are a lot of you with better eyes than I have, but I cannot really tell you whether the difference between 1 and 2 or 2.5 millimeters in a moving vessel in an angiographic view. So to answer your question, I want to have enough to make sure that I haven't missed the ostium, and have two, and when it's crushed, that it has 2 layers of metal in the main in the main branch, at the wall of the main branch.
And I think you alluded to this, Dimitri. Your practice for a DK crush is you will do, part to facilitate the recrossing, and then you'll finish with a kiss. Your last maneuver isn't a final part in a DK crush.
Correct.
And the reason for that is, you feel that you've already optimized the stent previously, and you don't want to distort the carina by inadvertently being too close with the balloon, or are there other reasons?
That could be a potential reason. But before I answer the question about the second part, and since I'm having a senile moment, remind me if I forget what you asked me. The port not only makes rewiring easier, but it makes it safer, in the sense that you have less chance of, unless you have a technique of shifting wires, of actually going behind the stent struts. So the first pot is critical. And then what was your question?
So what is your reason for not wanting to do the final part?
Yes,
finishing with the kiss?
because there is some evidence that it's mostly cosmetic. So instead of having a slightly oval vessel proximally, what the final pot does is it essentially makes it more circular. I think that's the main argument. I'm not sure there are any significant arguments for the final pot. And if you talk to people who were doing looking with IVUS and doing studies for a year with Gary Mintz and Akiko, they're convinced that there hasn't been a paper that there hasn't been any data that it actually affects restenosis or anything like this, MACE or the likes. However, there have been some papers that suggest that something that is expected, that the flow dynamics of blood in an oval shaped vessel are different, and the shear stresses are different than when you have a perfectly round one. And some people may make the argument that this is another good thing, and maybe that leads to increased restenosis, for example. I'm not convinced, so I don't do the final pot. But is it wrong to do it? No. So I think that's my answer.
And then could you give us some, often one of the, hitch points of these procedures where things become challenging is recrossing the side branch. Could, sometimes you cross it with a wire and you can't advance balloons or equipment. Could you give us a few points on how you troubleshoot that issue?
The rewiring,
or let's say the wire has crossed, but you can't pass any equipment into the side branch after deploying the main branch stem.
Yes. So one thing, one technique that you can do is to use a lower profile balloon, right? So if your 2.5 doesn't go, you can go to a 1.5 or a 1.0, depending upon the brand that you have. Another very useful tool and technique combination, because it's not important to have the tool, but you need to know how to manipulate it, is to have a microcatheter, like a Corsair or Turnpike or the likes. But again, it's very important. You need to know how to spin it and how to advance it. And so it's a technique in addition, it's a skill in addition to know that the profile of the several of these equipments. So that's one thing. Second thing that you could do is the anchoring technique, especially if you have already a stent distal to the bifurcation. You can inflate it, and then that anchors stabilizes your guide. And essentially, this is a little bit of a paradox. That's why I'm saying essentially without holding the guide, but holding the inflated balloon shaft, then you can push the side branch, equivalent to the side branch, and increase your chances of recrossing. And then another technique that you don't want to do, it's heartbreaking, and sometimes you need to try and rewire. It's a horrible feeling. It's like crossing a CTO and pulling the wire after a retrograde. You don't want to leave anymore. And recross. When I do that, I usually leave the first wire in, so that in case I think of something else to do, I don't regret that I don't have a wire. And then I try with a different wire. I don't recommend it, especially for fellows, but probably Yusuf remembers it. I like to recross to the Miracle Brother family. It's a very risky wire because it has a high gram force. It's stiff, in other words, on the tip, but it's extremely good tactile feedback, so you can essentially feel where the strength struts and go through in difficult to cross vessels. And also it's extremely supportive, much more supportive than the other wires that we use in order to recross. And it's also supportive, it's equally supportive until its main tip. And that's a very important characteristic that differentiates the Miracle Bro wires from other wires. Even our stiffest wires, the Ironman or whatever is available, Grand Slam right now, at the first 15 or so, whatever the radiopaque part millimeters is, they're not supportive at all. They start becoming supportive back here. And you may not have all that room to exchange for a wire of this kind if you won't have increased support. While the Miracle wires have the exact same support all the way to the tip.
Yeah, of course.
So when you're set now for a provisional strategy, what is your practice on the type of the guide wire that you're gonna leave jailed in side branch in terms of polymer jacketed wire or just regular wire? Do you have any opinion on that, and how do you practice?
There is actually data. So when I trained many years ago, I'm not going to tell you, I'm not going to reveal that secret today. It was forbidden even to think to leave a hydrophilic wire jail. The thinking was that as you're pulling back, you may strip off the polymer and leave material in the artery or behind the stent. So we, until many years after I graduated, I obviously you do what you're taught, right? But there have been a lot of people that were jailing hydrophilic wires, and there was a Jack CI paper, was it 2 years ago, or maybe before the pandemic, that actually showed that there's no such a thing as any issues with leaving jacketed wires. So I don't think that matters. I think that what may potentially matter is as far as wires, because there are also things that matter regarding that have to do with the anatomy, and I'll come back to this in a sec. I don't like to jail welded wires like a BMW, where you can actually see that there's a visible weld, because I've seen situations where in wires that are constructed like this, when you pull it back, that may actually catch somewhere and unravel the wire, and that's not a pleasant situation. So if I may make one comment that is very, I think, relevant to the question just asked, that we need to consider also two more things when we decide to jail a wire or not. Because sometimes you don't want to leave it jailed for too long. That's tortuosity and calcification proximally. That makes friction much higher, and there's a lot of resistance in pulling the wire. You may actually unravel it, or you may have the guide sucked in and have a dissection, so that's not a pleasant situation. The trick in a situation like that is you go with a microcatheter and a guide extension, and you try and go a little bit underneath the stent struts and start spinning it, spinning it back. So one is the anatomy proximally, and then the other thing is then the stent length that you will eventually need to have to keep it to stand against the wall. And a good example is, let's say that you have a diffusely diseased RCA with a bifurcation disease in PDA and RPL. So if you leave your wire jailed after stenting 120 millimeters of the RCA, then you may have trouble, I think, removing it, and you're going to run into issues. So in a situation like that, a good way around it is to finish what you have to finish with your initial stents and the bifurcation. Make sure that it's okay. Do your measurements, your high pressure inflations, have everything perfect. Then the bifurcation is not an issue anymore. You pull the bifurcation wire, you just carpet bomb stenting the proximal RCA. I'm sorry.
Perfect.
Can I ask a quick question?
Yes, of course, please.
All right. Thanks so much for an amazing talk. This is Carlos Davila, one of the junior faculty. I was wondering, what's your practice in terms of mechanical support, in terms of device selection, patient selection, and does that change your approach to bifurcation techniques? And do you leave the device after the case? Thank you.
How many hours do I have?
Well, that's why I asked. It's such an amazing operator, well known. I wonder, how did you select these patients? Because patient selection, it's all over the place if we looked at registry data. So I was wondering, what are your thoughts on that?
Okay. So first of all, You got it right in the sense that let's try and talk about bifurcations initially. We have to take into consideration the patient, right, and not just the lesion when we decide the technique. And I said it, but I want to emphasize again. For example, if you have a fragile 90-year-old or 80-year-old or someone in borderline shock or shockies or borderline renal function, then you want to keep things simple, and you don't necessarily want to do a perfect job at the bifurcation. So that will modify the selection of your technique, bifurcation technique, but not only if you're choosing two stents or with technique with two stents, but maybe it will lead you towards a provisional technique if you're dealing with the patient in a category that I just described. So the presence of bifurcation is considered a complex lesion, and a lot of these cases give the patient high ischemic time. So when I do a bifurcation technique, when I consider using a hemodynamic support or not, I take into consideration the same factors that I take when I want to decide if I want to put someone on mechanical circulatory support in any other case. To be honest with you, and to be honest, not just to you that you asked this good question, but to everybody, we don't know. We don't know. You're absolutely right. It's extremely confusing. The data can be spun whichever way you wish. So we don't have any real guidance at this point. And I think that's why I think the Protect 4 randomized trial, which is currently enrolling, we're about almost 50% target, almost. It's an extremely good study that is going to answer a lot of the questions that you just asked. In other words, when we don't know the answer, we say the approach is individualized.
Sounds about right. Thank you so much.
Hey, I had one quick question before we end. I just wanted to ask about osteal circumflex restenosis with two-stent strategies in the left main. Are there any ways to avoid it? Are there any strategies in terms of choosing your bifurcation strategy that can help prevent it?
That's our nemesis, right? The ostium of the circ. That's a weak point in left main bifurcation, and we don't really know exactly what it is. There are several hypotheses, but an interesting hypothesis that I heard relatively recently is that one important factor is how much motion you have during systole and diastole of the area of the carina of the left circumflex. One very, very interesting technique that I've seen and done when I was doing cases abroad is instead trying to avoid putting metal in the ostium of the circ and do a DCB at the ostium of the circ. That does not necessarily reduce restenosis, but at least it doesn't put you in a situation you have already metal. It may buy you some time, or you may get lucky and never to do anything like that. So I think this is an interesting concept that may start gaining some popularity, or at least I think it merits some kind of study to look into it. Again, I think the key thing is intravascular imaging. I'm going to tell you things that you know, because again, the ostium of the circ, I don't have anything novel to tell you except potentially the combination of stent in the left main LED and DCB in the left circumflex. Just use intravascular imaging, make sure the lesions are adequately prepped, and when you perform the technique, the PCI just try to whatever technique you choose based on the characteristic of the bifurcation, make sure you do it perfect. The left main is one vessel that the PCI is unforgiving, and if you're going to do it, you have to do it perfect.
Yeah, okay, great. So last quick question. Provisional left main LED stenting cross circ. Do you always kiss at the end, regardless of the circ status, or you do selective kissing at the end? Is the circ sacred territory that you always have to kiss at the end?
No, you don't. You don't always have to kiss at the end. And especially if there is no disease or it looks angiographically okay. Even if it doesn't look okay angiographically, interestingly, if you do even intravascular imaging, you just see that it actually is adequate ostium. And even if you do a functional study, again, you will see that that is fine. The answer is no. I do not routinely kiss in the if I do provisional from the LED in the left main. Since we are approaching the end, if you give me like 15 seconds, I'll tell you a funny story. I was doing a live case for the left main CTO summit. That's why that's how it used to be called many years ago. And I ended up with this situation. So you have panel of the experts, la creme de la creme of the operators in the world, and left main expert. So I do standing from the LED to the left main, I optimize and so on and so forth. And now the discussion starts, what are we going to do with the circ? There was no disease in the circ by IBUS before I stented the LED left main. So one said absolutely always. Then there was a disagreement, what size of balloon? Somebody else said never. Somebody else said maybe you need to do a functional study and decide upon that. So I said I like that idea. So I do a functional study. I put an IFR or FFR while we didn't have IFR back then, and it's negative. So I said, okay, now do we all agree that since it's negative, I don't need to kiss? And they all said, go ahead and kiss.
Yeah.
That's great. Thank you so much, Dimitri, and thank you for all the fellows and faculty for a great discussion. Yeah, we really appreciate your time, and that was terrific.
Thank you very much. I hope it was meaningful and useful to you. I certainly enjoyed the discussion, and it again great pleasure and honor to be with you this morning. And have a nice day. Let's get the day going.
Thank you very much.